In orthopedics, we use pain scales a lot. Almost always it's from 0 to 10, 0 being no pain at all, and 10 being the worst pain imaginable. And we use pain scales for a number of reasons. I would say in contrast to many clinicians, I don't use numerical pain scores very often. If I do, it's typically on the first visit, but I don't usually focus on that number very much. I obviously focus on pain as a subjective report that we want to improve or abolish, but I don't really focus on getting a number. So one of the reasons we use pain scales is that it loosely helps us with the diagnostic process. Just like any singular piece of data, it is not the end-all be-all, but it can help inform where we're starting to think in terms of diagnosis. For example, if someone's extremity pain without trauma is very severe, so 7, 8, 9 out of 10, especially at rest, then that raises the likelihood, in my estimation, of there being a spinal problem that's referring pain along a nerve that's either referred pain or radicular pain into the extremity. Those nerve pains tend to be more severe, for example, than non-traumatic injuries or problems in the extremity joints. So it doesn't mean that that's what the problem is, but when I'm probably collecting 10 or 20 different pieces of data in an evaluation, that one piece will either help me think it's more spine or more extremity, or if it is extremity or spine, what disorder is in those locations. So loosely, it helps us think about diagnosis. Secondly, when the patient's giving a pain number, it helps me understand, of course, how much it's impacting that person's life. A higher score is going to lead to usually decreased function and more of a problem in a person's life. But the main reason we use pain scales is really just to ascertain change, right? We're not comparing you to somebody else. Your 3 out of 10 pain is not going to be equivalent to someone else's 3 out of 10 pain. And I think patients get a little bit frustrated if you ask them for a number because they're like, well, I don't know what other people feel. I don't know how to give you a number. And it doesn't matter what other people feel. This is entirely subjective, and it's based on you, the patient's experience of this pain. In your life, is this something you would call a 1 out of 10 or a 9 out of 10? And patients can do that effectively because they're just comparing themselves to all the other times they've had pain themselves. So for me, we're comparing your 3 out of 10 to you a week from now, or you 10 minutes from now. So that is going to be clear because patients know if pain increases, decreases, or stays the same. When I do an intervention, and it's usually a singular intervention, but not always, but typically it's just one thing. But in the office, I'll just do one thing if I want to test it. So say I have the patient do a squat and it's 6 out of 10 knee pain, and then we do 30 repetitions of knee extension, moving into repeated knee extension, and I have the patient squat again. I'm not going to say what's the number of your pain with your squat. I'm going to say, is it worse, better, or about the same? And I tell patients this all the time. I speak in comparatives and superlatives. I'm looking for changes. Is that squat pain worse now? Is it better? Or is it about the same? And I don't say the same. I say about the same because I don't want to be splitting hairs. If it was a 6 before and now it's a 5.5, to me, that's about the same. That's not enough change to say it's conclusively better. So within that gray area, to me, it's the same because for many diagnoses, or for many problems, I find that the diagnosis is a mechanical joint derangement. And in those situations, for those types of disorders, I want to see change that is significant, that the patient really can say better. Because if they can say better, it's probably not a 5.5. But if I'm obviously asking them, is it worse, better, about the same, and all the other data suggests that this intervention or this movement is not making a difference, and they say it's better, I will definitely pry and say, well, how much better? I'm typically not using the pain scale in those situations either. I'm not saying, did it go from a 6 to a 5.3 or a 4.8? I'm asking, well, how much better do you think it is? Like 5% better, 20% better, 75% better? And if they're saying, oh, it's about 5% better or 10% better, to me, for that test, that investigation, that's about the same, which means it's probably not the fruitful movement that we're looking for if we're talking about a mechanical joint derangement. So pain scales are most helpful and most important when we just use them as comparing you to you. Is it different than it was 3 months ago? Is it different than 5 minutes ago? Is it going to be different in a week from now? We're just looking to see if that 5 goes to a 2 or that 5 goes to an 8. It doesn't really matter what that 5 is for you. Obviously, we would say 5 out of 10 pain is moderate, but for different people, that can feel like very different things. So don't get frustrated about this pain scale. It really is something that we don't even have to harp on. Sometimes I'll just use it mild, moderate, or severe pain, but it has its place, and sometimes it's helpful to get a number just so we can really compare you to your future you.